An obscure state healthcare process is getting its moment in the sun as a result of an advocacy campaign by health insurance companies in New York, which allege there is abuse and waste in the independent dispute resolution process used to determine some of the reimbursement rates in the state's healthcare system. The issue has also been targeted by Governor Kathy Hochul in her budget proposal, which amends the criteria considered for dispute resolutions with private insurers and removes Medicaid plans from this process. For more on the topic, we're joined on the Capitol Press Room by Bill Hammond, a senior fellow for health policy at the Empire Center for Public Policy, a conservative-leaning think tank here in Albany. Welcome back to the show, Bill.
Hi, David. It's a pleasure to be here.
Pleasure to see you. So right now, if there is a dispute about a bill for, say, emergency medical services or maybe a surprise bill, it gets resolved under state law by a certified, supposedly independent vendor. You've described the status quo as a racket. So what is it about the current landscape that isn't working?
It all revolves around Medicaid and how this law has been used by providers to extract money from Medicaid. When they passed this law a few years ago, my understanding is they did not expect it to come into play with respect to Medicaid because the whole idea was it was to prevent so-called surprise billing. And that's when you go to the emergency room, the hospital is in network, but one of the doctors who sees you isn't in network, and you get this exorbitant bill. Your insurance only pays a fraction of it, and you're stuck with the balance. Well, that doesn't happen in Medicaid because there is no balance billing in Medicaid. Whatever Medicaid pays is, like there's no consumer obligation there. Despite that disconnect where there is no surprise billing in Medicaid, providers, mostly on Long Island for some reason, have been filing tens of thousands of IDR claims against Medicaid in particular. And so I guess I should explain that part of the problem is that because IDR, independent dispute resolution, was never intended to work with Medicaid, the data that the arbitrators look at comes from commercial insurance. So there's this data set of all the claims that are filed by different types of specialists. And when an IDR claim comes in, the arbitrator is supposed to look at that data to see what the norm is for that type of service in that geographic region. But there's no Medicaid data in there. It's all commercial data. And Medicaid, for better or for worse, does pay substantially less than commercial does. And so the doctors are filing these claims and they're getting payouts that are based on commercial data, even though the payer is Medicaid. And in some cases, it can be, I cite in my blog post, I cite this admittedly an extreme example, but an insurer had the Medicaid managed care plan had to pay over $500,000 for emergency back surgery when the Medicaid fee would have been less than $3,000. So now that's an extreme case, but one reason people are concerned about this is that the number of claims like this has just been
Right.
skyrocketing.
Well, the response, though, from the governor is to remove Medicaid from this process, to explicitly say, we never intended this to be part of the independent dispute resolution process. But why do that as opposed to inserting the relevant data so that the comparisons are based on Medicaid reimbursement rates and not based on the commercial insurance rates? Is there a reason to throw the baby out with the bathwater, so to speak?
That would probably be an improvement, but that the counter proposal from providers has not been to try to fix the program. The counter proposal has been to keep the status quo. That's when I say from the providers, what happened was the governor in her budget proposed, as you say, carving out Medicaid and making a couple of other changes. And this is the second year she's made this proposal. And both houses of the legislature last year and again this year have struck that out of their one house budget proposals. So their position is we should keep the status quo. And the fact that these claims have been skyrocketing, quadrupling over a period of 4 years, they don't seem to mind that. I think just the increase in these IDR claims alone is cause for an alarm because it's a sign that something has gone haywire. You shouldn't have a dramatic increase in IDR claims from one year to the next.
But lastly, on the Medicaid front, if you don't have the so-called independent dispute resolution system to resolve these discrepancies, do we go back to what existed prior to this law? Is the governor proposing anything to fill a potential void if we just remove Medicaid managed care plans from this process?
I'm not sure what the discrepancy in a surprise billing law is between the amount that an out of network physician charges and what the health plan is willing to pay, which in the commercial world is relatively small. It might be hundreds of dollars or even thousands of dollars, but percentage wise, it's relatively small. What happens when you apply this system to Medicaid is you get like orders of magnitude difference, because Medicaid really is a different world where the fees are low, especially, I have to say, especially for doctors and for specialists. I would support a program that tries to readjust how Medicaid pays physicians. I think the Medicaid system is unbalanced. It pays too much to institutional providers and not enough to doctors. And that would be an improvement in Medicaid. That's not on the table. You know, year in and year out, the legislature debates how much more to pay institutional providers, and doctors tend to fall off the table. But the answer is not to have this, not to allow them to exploit a law that was never intended to apply to Medicaid. And for a small number of providers, a small group of specialists, to get exorbitantly higher fees while most doctors are living within the system.
So the other component of the governor's plan here is to amend the criteria considered by whatever independent dispute resolution entity gets a case. What are your expectations there in terms of potentially saving private insurers money? And is it possible that this is going to go too far and potentially hurt the bottom line of these providers that may have come to count on this money to support their finances?
Well, so what you're talking about is, so setting aside Medicaid for a second, we're talking now about how IDR applies to commercial insurance. And she is proposing a couple of changes. Probably the most important one is right now the arbitrator is supposed to look at the 80th percentile of rates, usual and customary rates. And she wants to change that to the 50th percentile. So more or less the middle of the range of commercial rates. She wants the arbitrator to look at that. And she wants the 80th percentile to be a cap. So no matter how much the provider appeals for, they could get no more than the 80th percentile. Those strike me as, as someone who's not, like, I'm not a lawyer, I'm not a physician, I'm not directly involved in the IDR process. Those strike me as interesting ideas. I guess I can't comment on whether they're bad or good. They don't seem to be the focus of the opposition, though. The focus of the opposition really seems to be in the Medicaid space. You've had members of the legislature say, well, I'm concerned that this will harm people of color, it will harm low-income people because specialists will refuse to participate in Medicaid. But actually, part of what's going on here is that in order to file an IDR claim, you have to be out of network. If you're in network, you've already signed a contract to accept the rate that the Medicaid plan pays. In order to file an IDR claim, you have to be out of network. And so you have specialists who are systematically removing themselves from networks. And so the classic situation is when you need emergency surgery and the anesthesiologist is out of network. Anesthesiology practices have been increasingly pulling out of networks and then filing IDR claims. And when that's in the commercial space, that drives up commercial costs. But when it's in the Medicaid space, it comes straight out of taxpayers.
You highlighted how the one house budgets, the priorities from the Democrats in the Assembly and Senate, did not include this measure. And I should point out that you're generally a great interview, Bill, but we actually had hoped to get the Assembly and Senate health chairs on first. Unfortunately, they didn't respond.
Yeah, I'm sorry.
So,
I'm glad to be your fallback option.
But yeah, what do you make of the fact that the point people for the Democrats in the legislature on health issues are not necessarily leaning into this one way or another? They didn't bite at the chance to come on and defend the status quo or to make the case for the governor's reforms.
I mean, I guess I can't speak for them. My perception here, though, is that this is a classic situation where the position of the Assembly and Senate is not being driven by any kind of grassroots movement among the members. It's being driven by behind the scenes by interest groups. Mm-hmm. The hospitals don't want this bill, and the medical society and the various specialist groups, they don't want the bill. And they have contacts completely legitimately and understandably. They have contacts in the leadership and the central staff of the Senate and Assembly. And I think that's how this is playing out. It's being discussed by the three people in the room as we speak, presumably, if they haven't already decided it. I mean, it's kind of interesting because the legislature will complain that they don't have leverage, that they can't change things, but they can. They can strike things out, and that this is an example of it.
What about the independent nature of this resolution system? I know there's a certification process for entities that want to get involved, but is there reason to believe that the players who are ultimately making this decision really are that independent and that their responses are basically just a product of the data they're getting? Or is there reason to believe that this is not necessarily an independent voice and that the system is kind of baked in the favor of providers for whatever reason based on who these entities are?
I haven't heard that complaint. I know in other contexts, so when labor contracts go to binding arbitration, I think there is reason to believe there are structural advantages that the labor unions have in those situations. I wouldn't be surprised if something like that was going on here, but I'm not sure. I think there's a term like baseball arbitration. The plan puts in an amount they're willing to pay, and the provider puts in an amount they want to be paid.
Sure.
And the arbitrator is supposed to choose between the two. They don't pick a number in the middle. They choose one or the other. And the idea is that's supposed to encourage people to pick a number as close to what they think is reasonable as possible. But when the payer is a Medicaid payer, and they're operating within the constraints of Medicaid finances, they put in a number, even if it's at the high end of what they think they can afford, it's nowhere close to the 80th percentile of commercial rates normally. And so the arbitrator looks at who's closest to the 80th percentile. There's a good chance it's going to be the provider. Even if the provider came in with a high number, that's kind of the structural issue here. The arbitrator is supposed to look at other stuff like, how sick the patient was and how long the treatment took and stuff like that. But ultimately, if the arbitrator is doing their job properly, a Medicaid case is going to look very lopsided. It's going to look like, the payer's just not coming close to the usual and customary rate, so I have to go with what the provider wants. I think it's a structural issue, and that's why the governor is taking a structural approach.
Well, we've been speaking with Bill Hammond. He's a senior fellow for health policy at the Empire Center for Public Policy. Bill, thank you, as always, for making the time. Really appreciate it.
Been a pleasure.
Fraud and lawsuit abuse raise car insurance costs for New Yorkers. Reforms are being proposed to mitigate their impact, but some Albany leaders want to keep the status quo. Information on these reforms is available at keepnewyorkaffordable.org.